In the other video, we discussed the somatosensory cortex function testing. In this video, we'll discuss stereognosis, fine touch discrimination, two-point discrimination, graphesthesia, and deep touch. These are commonly used tests to assess cortical function. What's agnosia? Agnosia is inability to recognize objects. It's an inability to process sensory information due to a lesion of parietal lobe. What's stereognosis? Stereognosis is ability to recognize hard objects like coins or a key by palpation with hands but with eyes closed. It's done only in one hand at a time and is done in the other hand also. Stereognosis depends on the sensory modalities of fine or discriminative touch, vibration, and proprioception. And what's proprioception? It's the position sense of different parts of the body in this space. Patient has to recognize the shape and texture of the object. And what does it need? It needs a normal sensory cortex and association area and intact primary sensations. Testing cortical sensation is only meaningful when primary sensations are intact. And what's astereognosis? Astereognosis is inability to recognize object like coins with closed eyes. Astereognosis is due to a lesion in somatosensory cortex or association area posterior to postcentral gyrus. And what's graphesthesia? Examiner writes numbers on the palm of the patient hand with eyes closed, and patient has to recognize these numbers. This is graphesthesia. And what is agraphesthesia? Inability to recognize the written number on the hand is agraphesthesia. And how about the two-point discrimination? Minimum distance to differentiate between two touch points on the body are different at different body parts and is minimum on the finger pulp and is 3 mm, whereas it's maximum on the back of the chest. And why it is so? Touch receptors are maximum on the fingertips. An area of representation of fingers on the somatosensory cortex is more than the other body parts. How sensations reach sensory cortex? To test for stereognosis, two-point discrimination, and other sensory cortex function. It's the fine or discriminative touch sensation which, along with position and vibration sensations, is responsible for sensory cortex functioning. And how do they reach there? They reach the sensory cortex via dorsal column. Dorsal column, first order neurons are in dorsal root ganglia, enter the spinal cord and travel through the posterior column in the fasciculus cuneatus and fasciculus gracilis ipsilaterally from upper and lower half of the body respectively up to medulla. So they go ipsilaterally up to medulla and relay in the nucleus cuneatus and nucleus gracilis, and then cross over to the opposite side as medial lemniscal system as second order neurons to the thalamus, and then to the contralateral sensory cortex as third order neuron to the cerebral cortex. Without a dorsal column lesion, these abnormalities suggest lesion in the sensory cortex of the parietal lobe. A lesion of the somatosensory cortex causes contralateral loss of discriminative sensation, of two-point discrimination, touch localization, conscious proprioception, stereognosis, and graphesthesia. Abnormalities of these tests signify cortical or thalamocortical projections lesion. With a specific parietal cortical lesion, loss of function is in the opposite side, so both sides should be tested separately. With parietal cortex lesions, most prominent symptoms are contralateral hemi-neglect, hemi-inattention, and a tendency to not to use the hand and arm of that side. With parietal lobe lesions, patient is unable to identify the stimulus on the contralateral side when both hands are touch. Thalamus is the great sensory relay station. A lesion of the ventral posterior lateral or ventroposterior medial nucleus of the thalamus causes decreased or lost sensations of discriminative function from contralateral body or face. But sometime in a stroke case, it causes severe pain on the opposite side of the body or face because pain fibers also pass through that. This is known as thalamic pain syndrome, also known as Dejerine Ro syndrome, and is a severe painful condition that starts a few weeks after the stroke.